So we're going to move on to our next behavioral category. This behavioral category, as we talked about, is behaviors which arise if there is impairment in actual information processing circuits. Now, so far what we've talked about is information processing circuits impact on higher cortical function. This is one behavioral expression that is the result of that same pathology that is responsible for creating all the abnormalities in your higher cortical function. And I'll explain what this is a bit more. So misidentification of persons, places, and objects. Misidentification of sounds, smells, tastes, and touch. Misconstruing of events and occurrences. And misperception of comments and behaviors of others. So I've tried to keep the language fairly simple so that we can explain this a bit more. But before we get into the specifics, I just unfortunately have to take you through a little bit of this information processing cascade, because it's important to understand this bit, because it is actually a key to understanding a lot of what we do in our daily life. So we talked about the information coming from body circuits, internal, external stimuli. We talked about this information coming into your information processing circuits. So once it gets onto the information processing circuits, then there's a cascade of things that happens, and it happens every single time, a gazillion times a day with everything we do. And the first thing is what we call a sensory memory, which is very transient, short-term memory, has its relevance. But really, it is not until that information gets into working memory. So working memory is the other name for short-term memory. It's a little easier, I find, to use the word working memory because I'll try to make some associations for you from your daily life to help you understand. So here is the most important thing. In order for a memory to be formed in your brain, it has to go through, the information has to go through a process that is called encoding. And again, we don't have to worry about the technical stuff, but there are two steps in that which are absolutely integral and important. And those are the last two steps. Schema identification and pattern recognition. As it speaks, it basically is saying, if I see a face, that's visual information, it goes into my brain, and it goes through all the steps, and then that information gets paired with stored information, your long-term memory. And what it does is two things. It tries to identify familiarities and patterns. And so schema is thoughts and pattern is vision. And then once I've looked at the face, I can say, oh, I know this person, because this new information has gone through and triggered something from the base information. And so long-term memory is formed after the new information has been paired with the old information. There is meaning given to it. There is context given to the new information, and then it's stored. So when it's stored, then you have in your brain zillions of these, what we call as mental schemas. So call them pictures, call them little footprints, call them whatever, like gazillions. And so every time your brain receives information in any format, hearing, vision, taste, touch, smell, talking, whatever, it goes through this process all the time, 1,000,000 times a day, to be able to say, I know this, I don't know this is new, this is old, all of that stuff. And the important part here is to understand, we have computers, we live with computers, and the computers, your kids will tell you, Mom, don't get a computer with less than 50 whatever RAM. Okay, so what that really means, what they're saying to you is, Mom, don't buy a computer whose working memory, the RAM, rapid access memory, is too brief, not good. You can buy a computer with a big database, hard drive, which is your long-term stored information. But if you don't have the right RAM, you will not be able to run programs, Mom. What's going on here? And I mean, that information is easy for them, but from our perspective, this happens every single day. Is the working memory is the RAM, the rapid access memory of the computer, and the long-term memory is the hard drive. And it's the pairing of the two information that gives meaning to everything. You can only run a program when you have a RAM, you retrieve information from your database, and then you make it run on RAM, and then it tells you what's going on. Same happens with the brain every single day. And this is integral. So what happens in misidentification behaviors? So for you to have misidentification behaviors, there is that breakdown of the information, the new information, and its pairing to the old information. So pairing happens, but not in the right way, because the last two steps of that process are impaired. And so what ends up happening is the meaning and the context given to new information is altered. So if I take a face I've never seen before and pair it with a face that resembles one of my case managers, and I go give this person a hug, I'm in trouble. Because that's what happens, is we've paired the wrong information. And what's even more important with this particular behavioral expression is the information that seems to be affected is the information that is of greatest personal importance to that person with dementia. So these are monumental bits of experiences and information in their lives which seem to be prone to this mismatch. Not just run-of-the-day, run-of-the-mill information, only very important information. And what that does then is it creates that altered sense of relatedness. So your relationship to new information is altered. So the person and the environment are not doing what's supposed to happen. And that is because of those proteins and strokes and whatever on the information processing, in particular those two steps, so that the pairing is gone. So what happens? We'll break it down even more. We talked about misidentification of peoples, places, and objects. These are all visual stimuli, right? This is all vision. I see places, I see faces, I see objects. And then you've got other perceptions, hearing, taste, touch, and smell. And then we have events and occurrences, which are larger, sort of a movie in your environment. Events are happening, occurrence like a movie running around you. And then, of course, finally, what you may have said to me if I was impaired, or how you may have behaved while you were caring for me while I'm impaired, those bits of information. So what happens? Let's give some examples. If, and you see this all the time in your daily world, if the facial, people, People, places, objects. People, places, objects. So people, faces. I look at a face, I gave you the example. If it gets paired with a face, it's not meant to be. In our world, what we see is misidentifying another person as your wife. And, and that, of course, comes with its own challenges. But what's happening here is something in that individual's facial profile got paired with the picture of their wife in their brain, not from today, maybe 30 years ago. The eyebrows look the same, the smile is the same, but just enough mismatch. Then you start to walk around with these people, and we see this all the time. Don't come near me, that's my wife, none of your business. Same thing happens when you take the environment, places, non-facial. Oh, this is my home. These guys are all here. They're not paying rent. Get them out. How many times do you have these guys hurting everybody else, and then you go and, oh, it's not your home. Oh, and you get into fight with them as well. So it's that pairing, because what it is, maybe one of the cornices in that nursing home reminded them of their home. Maybe the furniture layout, maybe the carpets. It's that pairing that went wrong. The other thing is objects. One of the commonest things I see, when I used to evaluate people in the early stages, is to look outside the window and look into the tree and say, see those faces in the tree? And I don't know how many people come to me with that being labeled Lewy body. Because they have visual hallucinations. No, they don't have visual hallucinations. What they have is visual misidentification. They are looking at structures in the tree, and it's making them look like, oh, those are faces. And they're saying, look at those faces. Or similar things. So the difference is the stimulus is there. The visual stimulus is there. But it is not paired the right way. So the meaning you put to it is altered, and it presents itself as a behavioral expression that we have to deal with in our care. Again, keep reminding, the information we mispair is of extreme personal importance to us. So the examples I'm sharing with you are examples of people that I've collected over the years, and we've gone back in their history to make sense, to understand. So we had this person we saw in one of the long-term care. We were called in because he wouldn't go for bath and whatever else. He was on the bed all the time. And one of the things that happens in long-term care is the maintenance guys will put a little piece of cloth to see if the vents are working. And it was flapping. And it was making a gushing sound, And so we went in, we said, let's talk to this guy, short of the long. Turns out the reason he wouldn't leave the bed is because he thought the room was being flooded with water. And he didn't know how to swim. So he's not going to get off a safe, dry place. There's no way he's going to leave that. And it turned out he was stuck, his basement got flooded, and whatever. So something of great personal importance. But the way to approach it for you guys is to break it down into simple: vision, hearing, taste, touch, smell. No complicated terminology, just simple. Taste, we all know how many times we get told the food's poisoned, right? I mean, and obviously sometimes we know we put medications in there. but regardless, we're very careful in the type of medications we put. We put effervescent there, tasteless, odorless, and smellless. So, similarly, I've had examples. This was a classic example in Wentworth Lodge in the old building. They used to make their own breakfast, and we got called in to see this person who thought the building was on fire, and he would start to act that way. It was always around the same time. It was because they would do these toasts. There's one or two healthcare staff running all over, putting toast toast in the oven, in the toaster, making sure that it gets done fast, it's on high, it's burning, it'll smell all over. But what they were doing is, the smell they got reminded them of their experience with their house having burned down. So it's that pairing. And again, all of this comes down to the personhood. Remember the person who's carrying the disease and their life experiences. This is what it's all about. And so the pairing of that information went awry, and hence you got symptoms, expressions which didn't make sense to us, but for them it was real. It was because of that wrong pairing. Tactile. I mean, we've seen this. You give someone a shower, and the next thing you know, they're on the phone saying, they held me down, they handcuffed me, they beat me up, and all of that stuff. It happens. And then, of course, the families come and they put cameras in the room, and then they record you. They put little bugs here and there so as to make sure their loved one is not being abused. But if you look into the history a little bit, you'll find that physical trauma was significant for this person in their lives. So anyone touching them a certain way, is a pairing of information, tactile information, to the information that reminds them of that trauma. And therefore, they're calling their daughter, who then comes and sees the DOC with 20-page letter to say how their loved one was abused. And God forbid there is a bruise there by any chance. You're done. We've had this case upstairs. A very, very lovely healthcare professional got accused of sexual misappropriation by another patient. From where it came, how it came, it completely put their person's life on hold. I can't even imagine. And this was happening with a family who was making our lives very difficult. So now imagine the daughter gets a phone, and you know what? I mean, the patient had to be transferred for a sexual assault evaluation. It was a nightmare. And it was all about a simple misconstruing of comments and behaviors of this individual. But it's important. Events and occurrences, particularly our war veterans and other trauma patients and how they respond to noises, EMS response. Something major is happening. What they're basically doing is, there's a lot of chaos, there's a lot of commotion. They're pairing that information with the past experience during wartime combat or any other trauma, and then coming out with an interpretation that is entirely different. So it can happen with events, it can happen with occurrences, it can happen with what you as a healthcare provider is saying to your patient, and they may say, this is what you did, this is what you said. And it can make it very, very difficult. So the important thing is to remember that there is mispairing of those perceptions and events and occurrences and those sorts of things. So what is the purpose of this measure? Why are we having this conversation? So for you and I as healthcare providers, what it really is meant to tell you that there is an alternative approach to evaluating, assessing, and understanding psychoses in this cohort of people. And the reason why it's important to understand this, it takes us back to what we were talking about with an MMSE of 9 or less. If I have to demonstrate someone has a delusional belief, then delusional belief has a definition. A fixed, false belief, which is not in keeping with an individual's socio-cultural, educational, and spiritual background. So I have to put every belief they share with me. When they say, I'm being followed, that's a belief. Then I have to put that belief to all those 6 tests to label someone as being delusional. I don't know how often that happens in the real world and how often we are quick to label, but the reality is we have a responsibility there. Because people get labeled paranoid when you don't even know what it means, because we haven't put them through those tests. Now, coming back to the validity and the reliability of the interview with a person who has an MMSE of 9 or less. Is it even possible? No, it's not possible. You cannot conclusively say that this person has a delusional belief. And at the same time, I know even today, as we speak, it's a Thursday, when the medical students and residents were taught yesterday to ask questions. Do you hear anything nobody else hears? Okay. Listen, if I could distinguish, then I wouldn't be psychotic, brilliant doctor. I'm hearing things because they are there and they are real. So try asking a question to an MMSE of 9 or less. Ms. Smith, do you hear voices nobody else hears? So it draws into big question, how do you evaluate psychoses in this cohort of population? And the reason why it's important is because we all know our primary impetus is to minimize and reduce the use of atypical antipsychotics. And according to what I have been developing, there are very few behavioral categories that require atypical antipsychotics. The rest don't. But when we really need to, we don't. And when we don't, we do. The key is to understand the individual, the behavioral expression. That's the purpose. So what is the meaning? What is the individual who is impaired and can hardly communicate to begin with telling you? What is the meaning of their communication to you? What they're saying to you is, dear care provider, my thinking is not based in reality. Please pick up. I don't want to cause any problems for anybody. But if it's causing distress to me, help me. So it's kind of that, I put this in quotation, paranoid. I dislike the word, but somehow it's in our vocabulary so strong that it really is a way of them saying to you, I'm not right. Something's misfiring, and it's causing me to do things I don't intend to do. And in the process, people get into trouble. There's so many examples, but this was the most extreme we had recently in the last 6 months at St. Peter's Hospital. If you can start to recognize that, then this is the approach to care. Easy. We talk about paired care. 2 people go in, you document. So one is a witness to others, so that if there is any chance of being accused, which is a strong word, but it happens all the time, we are dealing with a vulnerable population. This is where whatever you do, you go beyond what they tell you in GPA to explain everything. And what you do not do as you are is challenge them. It is what it is their reality, it's what they're doing, they're mixing things up, let it be. But if you were to communicate with them in detail, which takes time, and I know time is not always available, that's where you call BSO. and they can do this for you, because sometimes just talking, repeating, slow can make a difference. You don't have to go to medication. Because all of this that we're talking about today is really, the bigger goal is to minimize the use of medications. And I've always said that they're essential, they're critical, they're important. I'm just hoping to streamline things so you can do the right things for the right people in the right amounts and not overdo it. And so if you guys can do this, then it allows me to use less medication. But the key is, and then detailed documentation. And this is for your own protection. But it begins with you being able to recognize that the alternative way of evaluating quote-unquote paranoia or psychoses in this cohort of people is to recognize the misidentification of simple perceptions. And you're not having to then put them through all the paces of what needs to be done.